I want to welcome you to the Cognitive Behavioral Therapy for Psychosis Stepped Care Training. We'll be providing a 1-hour webinar today looking at an overview of the CBT for Psychosis Stepped Care model and the referral process. My name is Sarah Kopelovich. I'm a faculty member at the University of Washington in the Department of Psychiatry and Behavioral Sciences. And I developed CBT for Psychosis Stepped Care and its application in community mental health agencies across Washington State. The Stepped Care model is being brought to your agency, and we're hoping to enlist your help in providing referrals and screening new clients so that they can participate in the CBTP Stepped Care process. So I'm excited to tell you more about it today and to train you up on the tools and measures that you'll use to make level of care decisions. So let's start by talking about what is stepped care. Simply put, stepped care is about doing more with less. Stepped healthcare is a system of delivering and monitoring treatment so that the most effective yet least resource-intensive intervention is delivered to patients. Stepped healthcare is a model that stems from the medical healthcare system, where there was a need that was recognized to deliver more effective interventions when the interventions were themselves limited, or the folks to administer those interventions were limited as well. It's a popular and intuitive model, and in fact, King County Behavioral Health Organization and other BHOs around the state use the stepped care model on a larger scale to target the appropriate intensity, type, and frequency of services that are delivered to clients. So the intent of stepped care is to conserve limited resources while still getting the appropriate treatment to those who need it. This occurs by beginning one's therapeutic efforts with the least intensive, expensive, and intrusive intervention possible for that client at that time, and then moving on to more expensive, intensive, and/or intrusive interventions only if deemed necessary to achieve a desired therapeutic effect. CBT for Psychosis is an evidence-based psychotherapeutic intervention that at this point has just over 50 randomized clinical trials, over a dozen meta-analyses, and 3 systematic reviews that support its helpfulness for a lot of folks with persistent psychotic symptoms, as well as folks with just 1 or 2 episodes of psychosis. Despite its pretty robust evidence base, CBT for Psychosis is largely inaccessible to individuals in the United States. Kim Muser and Doug Nordze estimated pretty recently within the last couple of years that only 0.1% of licensed mental health clinicians across the United States have been trained in CBT for Psychosis. In addition, CBTP is often taught to highly experienced and highly credentialed therapists, which limits access even further and makes it very difficult for folks who are in rural populations or underserved areas to be able to access this expert care. The scarcity of CBT for Psychosis makes this intervention a potential candidate for a stepped care approach. The other piece is that it turns out that CBT has actually been identified as a prime candidate for stepped care. And that's because within CBT, you have a wide variety of interventions that are amenable to a stepwise application. So the idea here is that my team and I at the University of Washington can train a range of disciplines at your agency. So peer specialists, registered nurses, case managers, therapists, and we can train them in variations of CBTP that vary in complexity and intensity. They can then offer those CBT packages to individuals with psychosis, in addition to whatever other care they're already getting. This approach has been piloted for CBT for depression in the United States, and within the last couple of years was also piloted in the United Kingdom for CBT for Psychosis. I've applied these lessons that we've learned to the current model of CBT for Psychosis stepped care that's currently being rolled out in your agency and others across our state. So the end result is that CBT for Psychosis in some form should be considered and offered for all new and existing clients with a psychotic disorder at your agency. And in that way, we're really trying to shape the culture of care for psychosis, that there are active psychotherapeutic interventions that can really make a big difference in people's life. So there are two fundamental features to CBT for psychosis stepped care, and we'll talk about both of these. One is that the recommended treatment within the stepped care model should be the least intensive of those available, but still likely to benefit the person. So I've talked about that piece already. The second is that the stepped care model should be self-correcting. So we should be monitoring continuously and making adjustments as needed. And that monitoring and adjusting process is something that is so embedded in the model, and that's where our screening measures come in. So for those of you who are visual learners, like I am, here's a CBTP stepped care diagram. So what we have here is the general patient population would represent both new and existing clients at your agency who meet criteria for a psychotic disorder. And we would then get their consent to participate in the program and do the screening process. At that point, we would put them into the lowest level of care that would meet their needs at this time. And then we would do an assessment at the end of that step of care to determine whether that person needs to be stepped up to a higher level of care, if they are either still symptomatic or more symptomatic, or if they can be stepped down gently to the next lower level of care, or if in fact we would be able to justify that they would either go back into the general patient population to continue receiving their other services, or to perhaps discharge from the agency with appropriate supports. So you may also be hearing terminology like track 1, track 2, track 3, in addition to step 1, 2, and 3. And the difference here only refers to whether this is a client or a provider. So clients are receiving steps of care, step 1, 2, and 3. And then our providers are going into training tracks. So obviously track 1 providers would be providing step 1 level of care, which is our low intensity CBT for psychosis. And that consists of recovery-oriented psychoeducation and some very basic behavioral coping skills and cognitive coping skills. Our track 2 providers are providing our step 2 CBTP, and that consists of group CBT for psychosis. And our track 3 providers are, of course, providing our step 3 CBTP, which is considered high intensity. They'll be meeting one-on-one for about 24 sessions for 50-minute sessions each, providing the full range of the conceptual model of CBTP and the interventions. So let's talk about how are level of care decisions made, and this is probably the most important aspect of this training. So I want to refer you all to the CBTP Stepped Care Referral Guide. The first thing that you'll notice at the top of the screen, and you can see it, I've just put a little bit snapshot of it on this slide, is that it assumes that we already have diagnostic clarity that this person does meet criteria for a primary psychotic disorder. For the most part, we do want to screen out affective psychosis, so for instance, bipolar disorder with psychotic features. And the reason for that is that there are evidence-based treatments for mood disorders that we would want to have as our primary treatment. We can be a little bit flexible with that with the group CBTP if needed. I know sometimes when we work with large multi-site agencies, some of the smaller sites have trouble just with a patient population that would be big enough to get a group going of folks who only meet criteria for a primary psychotic disorder. And sometimes that's the case with some of the smaller agencies as well. The other thing that I want to make you aware about in terms of the CBTP referral guide is two things. And these are common questions that come up among providers and agencies. One is what to do when somebody doesn't agree with their diagnosis. And we would say that this should not be a barrier to treatment, that you'll just want to be really careful about the language that you're using with that client so that you don't disengage that client by using labels or language that does not feel comfortable to them. The other issue that comes up frequently is the question around substance use, and we have a fairly clear guideline around when somebody meets criteria for a substance use disorder, which will likely be the case for about 50 to 60% of your folks with a primary psychotic disorder. And what we say is that if you have reason to believe, particularly based on recent past experience, that the person's substance use will interfere with their ability to engage in the treatment, to come consistently to sessions, and to arrive sober, then it might be best to start with motivational interviewing, and then to follow up when the person is ready with CBT for psychosis to target their psychotic symptoms. Otherwise, the substance use disorder, even if current and ongoing, should not be a barrier to their treatment. The decision about which step to place a client with a psychotic disorder in will depend on two factors. One, of course, is client preference. We want to make sure that the client can make a knowing and voluntary decision about their participation in this program. And the other is clinician screening. So we'll talk about those two things in the order that I just presented them. So let's talk about client preference. So I have two little pieces of recommended language here to use. And the first is in italics, how you might talk about this with a client before you've actually engaged in a little bit of a clinical interview to get the information that you need to score the screeners. So for instance, you have an opportunity to participate in a program. It will be helpful to talk together today to get a better sense of which offering within this program will be the best suited for you. And you might also want to say a little something about how this is a program that involves a treatment that's been helpful for a lot of folks that have similar experiences or similar symptoms as they have. After you've done the assessment, you've had the ability to look over the scores and determine their level of care, you'll want to provide that recommendation. So for instance, it seems like you'll benefit quite a bit from a new group at our clinic that's led by so-and-so. This group is all about learning new ways to identify and manage stress and to identify some helpful ways of thinking through problems. People who participate in this type of group tend to see a lot of benefit to all sorts of symptoms like anxiety, depression, hearing voices, and having lots of distressing concerns. So you'll see that there shouldn't be any language in there that might ostracize somebody or disengage them, but we're still able to provide some level of detail about what the group is about. If the client is reluctant, then we'll want to use some motivational interviewing skills, right? So a lot of folks, particularly folks with paranoia, or who engage in a lot of isolative behavior will say, I can't go to a group, it's too intense, I just couldn't tolerate being around that many people. And the inclination, I think, is to say, okay, let's figure something else out. I would say first, let's see if we can work with the client to troubleshoot this issue. So it sounds like you're concerned that your paranoia will be overwhelming in the group room. I wonder if we could go together as observers to test that theory out. Or if that's not possible, if you could go with, if there's a peer specialist who could accompany them to the group, or if they even would just be willing to go to the first three groups to test their level of discomfort. And I might even say that would just be a trial period to that individual, and perhaps they might even consider sitting on the periphery of the group or sitting near the door. You'll, of course, want to alert the facilitators of that group if that's the situation. And we can also use our motivational interviewing skills to explore this with the client. So we'd use our ORs, those open questions, affirmations, reflective listening, and summarizing. If it's absolutely necessary and the person will not agree to the level of care that you think would be best for them, then you might say, why don't we start off with this different step instead, given those concerns, and revisit this option down the road. So you're not closing the door to the possibility that they would participate in that level of care at a future date. So let's talk about the clinical screening. So assessment is really the key to evidence-based practice, and it also happens to be critical to stepped care, as you saw that it was one of the two defining features. We also know from a large body of literature that measurement-based care improves decision-making and clinical outcomes. And a lot of agencies around the country have been moving more and more to measurement-based care as standard. You're going to be using two assessments to guide your professional judgment, and I want to refer you to the CBTP Stepped Care Assessment Guide, which lays out in writing everything that I'm going to be talking about with you today. We'll cover two screener assessments, One is called the Clinician Rated Dimensions of Psychosis Symptom Severity, also known as the CRD-PSS, or informally among our group as the DOP, because it's a lot easier to say. And the second is the SOFAS. So the SOFAS is the Social and Occupational Functional Assessment Scale. And this is really a measure that you will see looks extremely similar to the GAF. The GAF was rated from 0 and 1 to 100. The SOFAS has that same scaling as well, but it really hones in on functional impairment that's related to those two domains of social and occupational functioning. So let's start with the DOP. And we'll see it on the screen in just a minute, but let's just talk quickly about what the DOP is. So this was a measure, a screening measure that was proposed by the DSM-5 task force to be administered at intake and to monitor treatment progress for folks with psychotic symptoms. The DSM-CRD-PSS scale adds valuable information to the categorical diagnosis of schizophrenia, which is relevant for antipsychotic response. I would really say that this is not a diagnostic inventory whatsoever, that this is really, as the title says, this is about measuring the severity of psychotic and related symptoms. We'll be using this as a clinical decision-making tool as it was intended to be used. So this measure is completed by the clinician during the interview or immediately after. When you administer the DOP, when you score the DOP, there'll be three things that you'll want to do. You'll want to, if you've administered it, if you've completed a pencil and paper version, then you'll either want to scan that into your electronic health record, or you'll want to, if you have it embedded already into your EHR, then you can just put the item responses directly into your EHR. The second thing you'll want to do is, of course, note in your progress note that the DOP was scored on that day during that encounter or immediately after that encounter, and note the score with some interpretive, with some interpretation within that note. And then the third thing would be to enter it into the evidence-based practice toolkit, or the EBP toolkit, and that's at ebptoolkit.com, which is something that our team has been using for many different agencies for clinicians to be able to share clients and be able to track that client's progress and their response to the treatment across levels of care. So when you screen somebody in, let's say client X, and you enter their scores, you make the referral to the appropriate step care provider, and then that care provider can then enter their scores the next time around. The other thing is that, I just want to go back to that for a moment, you can actually enter those scores directly into EBP Toolkit, so instead of a paper and pencil version. And what's nice about that is that when you go into the toolkit, when you hover over certain words, then what you'll see come up is a definition for that word. So for instance, catatonia, prosody, delusions, hallucinations. When you hover your cursor over those words, you'll have those definitions, and that kind of helps us a little bit with that reliability. All right, so this is the DOP, and one thing that we did, this is originally an 8-item measure. This is now a 7-item measure. We took out one item that related to cognitive functioning because it assumed that you had done some sort of cognitive screening and were aware of this person's SES. And we didn't know that those would be reasonable assumptions to make for all agencies and all clients. So what we have left are 7 items: hallucinations, delusions, disorganized speech, abnormal psychomotor behavior, negative symptoms, depression, and mania. And you'll see we have a 0 to 4 Likert scale. And you'll also see from the instructions, which we'll talk about more in a moment, that we're looking at these symptoms within the past 7 days. So 0 would be not present. 1 would be equivocal, and within the parentheses, you'll find a little bit more explanation of what equivocal would look like for that item. 2 is present but mild, 3 is present and moderate, and 4 is present and severe. So the instructions are found, as you just saw, on the tool itself. They're found again in Toolkit and also on the CBTP Stepped Care Assessment Guide that I referred to a little bit earlier. We talked about the rating scale and the number of items, and we talked about the definitions provided in EBP Toolkit. There's also an additional hard copy of the glossary that we can provide that just lists all of the different definitions. So for our purposes, we're giving the greatest weight to the psychotic items. So that would be items 1, 2, 3, and 5. And you'll score each item, next you'll want to look at mood items, so depression and mania. And you want to score each item independently. So a rating of 4 on item 1 should have no bearing on item 3. To score each item, you want to be looking at a few things. One is, what are you seeing? What is your clinical observation? And second is, what is the client's report? And third would be, what a report from any collateral sources you have. And that would include both current and former treatment providers, as well as their natural supports. And bear in mind that for this measure, we are only interested in how symptomatic they've been within the past 7 days. So unless you have a former treatment provider that can attest to that, that type of collateral may not be as much help as the current treatment providers or other members of the treatment team. So let's go over a few of the sample questions for the more relevant items for determining level of care. So item 1, which refers to hallucinations, all types of hallucinations. I focused in on voices here in these sample questions because anywhere from about 60 to 80% of folks with a schizophrenia spectrum disorder reports hearing voices. It's less common to have visual hallucinations and even less common to have olfactory and tactile hallucinations, but certainly if that is that person's experience, then you'll want to change the wording. So questions include, can you tell me about how the voices have been for you in the past week? How intense have they been in the past week? And I'll give a 0 to 10 rating scale and then provide some anchors for each of the, for 0, 1, and 10, maybe 5 as well. Are the voices as loud and clear as my voice is right now? How often over the last week did you hear the voices? How bothered have you been by the voices in the past week? Did you feel the urge to act on the voices, on what they told you to say, or in any way change your behavior? And this would include, and I think often does include, more isolative behavior. It can also include things like skin picking, substance use, and sleep. How difficult was it for you to resist the voices? And then you would assess for some of the less common hallucinations, sensory misperceptions. So item 2, sample questions. This is sometimes a little bit more difficult for folks to elicit delusional content. What types of concerns or worry thoughts have you had in the past week? How have you been getting along with others? Are there some people who you don't trust? Are you concerned others might be talking about you or trying to harm you in some way? And I might follow up with how much time they spend worrying about these things. Do you have concerns about other people reading your mind or hearing your thoughts, or even maybe controlling your behavior? Any special powers, talents, resources, or abilities? Concerns that you're getting messages from the TV or the radio or other sources? And then how have these thoughts or concerns affected your day-to-day living in the past week? For item 3 questions, you want to be thinking again about that past week. Have you had any difficulties expressing what you want to say to other people? And here I think we can rely quite a bit on our observations of how linear their speech is in the context of our interview with them, and you can supplement with their responses to these questions. How often has that happened in the past week? What types of challenges have you had in organizing your thoughts? And what have you done when this happens? Also, is there any evidence of thought stopping or other types of disorganized symptoms? For item 4, let's just say a word about that before we move on. That's the abnormal psychomotor behavior. You want to remember that you're looking for signs and symptoms of bizarre motor behavior, perhaps some awkward posturing, as well as some muscular rigidity or stupor. And again, some of those definitions of what we're looking for on that item would be in the EBP toolkit or in the glossary. And most of that, of your scoring for that item is going to be based on your clinical interview with that individual and perhaps some additional information that might come from the intake, anybody else who did that intake, or the psychiatrist or nurse practitioner has met with them. So in terms of our referral guide, as a rule of thumb, now remember that we're prioritizing our psychotic items. We want to be looking at, for CBTP step 1, we're going to be looking at mostly 0s and 1s. For CBTP step 2 referrals, we want to be looking mostly at 2s and 3s, so a mild to moderate range of symptom severity. And for CBTP step 3, we're going to be looking at mostly 3s and 4s. And this is critical to the entire CBTP stepped care model, because we really want to make sure that our provider is not getting somebody who's inappropriate for the level of care that they're trained to provide. And we also want to be reserving the precious resource that we have of the limited number of providers in each of these steps to make sure that we're making the best use of their time. The second screening measure that we'll look at is the impairment that's caused by the psychiatric symptoms. So the SOFAS is, as I said earlier, designed to assess level of functioning. It's also useful as a clinical decision-making tool as opposed to a diagnostic tool similar to the DOP. It is to be completed by the clinician either during the interview or immediately after the person leaves. Most people, as with rating a GAF, can rate a SOFAS extremely quickly, certainly in about a minute or less, and that's one of the reasons why the SOFAS is such a nice, and the GAF are thought to be nice tools in that way. And after you administer, you'd go through the same procedure. You could upload it to the EHR, although I think most likely it'll be most easily reported into the note itself and entered into the toolkit. So on the SOFA, something that's really important to point out is that many people think that the scale ranges from 0 to 100 because you'll see a 0 on the scale. It does. However, the value of a 0 is that you have inadequate information to score. The rating of social and occupational functioning falls on a dimension of 1 to 100, where essentially 1 is somebody who's non-responsive, catatonic. 100 would be optimal level of functioning in those two domains. That's something that I think we all aspire to. On the scale itself, you'll see anchors that are provided to give you more clarity about what range somebody would fall into, and then you'd make a further determination about within that range, do they seem to be on the low end of that range, in the middle, or at the high end of that range. One thing that I really want to clarify that's quite important to this rating is that on the instructions for the SOFAS, what you'll see is that it asks you to rate level of functional impairment that's caused by either psychiatric or medical symptoms. And for our purposes, that doesn't really help us a whole lot with making level of care CBTP decisions. So we only want to focus on the impairment that is caused by the psychiatric condition as best we can tell. So the person's not leaving the house because of their voices, or they haven't gotten a job, they haven't held a job for years because they don't feel like they could leave the house, or the last time they held a job, they had a psychotic episode. That would be a good indication. So again, I want to provide you with a few sample questions for the kinds of things that might help you rate the SOFAS. So things like, how have you been spending your time this past week? Have you had any days in the past 2 weeks when you had trouble taking care of yourself? Tell me about the worst day you've had in the past 2 weeks. What did your best day look like? What did you do? Are there times when you lie or sit around most of the day? And this is something that would also help you potentially with some of the negative symptoms for the negative symptom item on the job. Tell me about work or school, and if they're not engaged, really trying to find out whether the symptoms are the reason that they're not engaged. who do you spend time with outside of the clinic, and try to assess both for social, familial, and romantic relationships. All right, so at this point, it would be helpful to start to look at an example. And what we'll do is we'll start a clinical interview, and we'll all take out the DOP and the SOFAs, and I'll have each of you rate the DOP and the SOFA, the DOP, and we will go over some of those ratings.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor, because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you, and some rather distressing experiences. So I think the doctor thought it might be helpful for us to have a bit of a discussion about that, to see if I could help. Would that be all right with you?
That's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
You're going to think it sounds stupid. My housemates are working for MR5.
Right.
And they're doing stuff to my brain.
Okay.
They're out to get me.
Okay, that must be very difficult for you. How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out this, what was happening?
I came home one time and the movie. I went to TV to me, so I knew then.
And what was it that you knew at that moment?
Did the work for MR5.
Right, okay. So it's been going on a couple of months.
Yeah, this new lecturer started with me, and he works for MI5.
Right.
He basically drafted my housemates in, running against me.
Okay. Now I've noticed a couple of times while we've been talking that you sort of look round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Oh, I can hear him talking.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3.
Okay. And does it sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not up here.
Right.
And
so what when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like he's left the house now.
Okay.
Yeah.
Anything else? Do they ever talk to each other, perhaps, about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them.
Right.
And they're saying like I'm making trouble.
Okay.
And they're going to sort me out.
Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
Yeah.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Had any experiences like that?
Yeah. I do think things that aren't me. Like they're putting stuff in my brain. It's not me. I'm not thinking.
So different thoughts in your brain.
Yeah, it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch it.
Right. It's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening? Or who's responsible?
It's MI5. It's this chip that put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No,
Nothing like that.
they're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
If anything, there's too much in there. I wish I could unplug it.
Okay.
Get this thing out of my head.
You mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and then I can feel it really well, like rotating
You can
around.
feel the physical sensation in your brain. Okay, that must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
I feel fine. I'm not ill or anything.
Okay.
Just want this thing out of my head.
But it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I'm not really leaving my room much. And I sort of have to wait till they go out just to go down and get some food. But they've been doing stuff to my food now, so.
Okay. What do you think's happening to your food?
They're poisoning it.
Okay. Are you actually eating much at the moment?
No.
Okay. And with all this happening, and this sounds like you don't feel very safe, have I got that right? Okay. Have you felt the need, I don't know, to take steps to protect yourself in any way?
Well, I've got a knife.
Okay.
And I've got a baseball bat.
Right.
It's just in case they get in my room. I don't want to hurt anyone. I just feel like I've got to protect myself. It's like cornering me to do this.
Right, okay. Have you felt the need to use either the knife or the baseball bat so far? But to take it out with you for protection?
No, I don't want to get caught.
Okay.
It's just in my room.
Okay. Has it ever got so bad, Andy, that you felt the need to hurt yourself or even kill yourself as the only way out, the only way of coping with this?
I thought about getting some pills, but I couldn't leave the house, so I didn't get anything.
And when you say getting some pills, would that be to take an overdose of tablets?
Yeah.
But you've not actually done anything about that so far? Okay. In the past, have you ever had any problems either with your temper or getting into fights, being aggressive, either with your housemates or anybody else?
No, I'm not that kind of person. I don't want to hurt anyone. It's just driving me to this.
And can I just check again, you've not been in trouble with the police or anything like that?
No.
Okay. With all this that's going on, is there anywhere at the moment, Andy, that you feel safe?
My parents' house.
Right, okay. And have you seen much of your parents recently?
I thought about going down there, but I don't want to drag them into it, so I don't want my father to know about it.
And throughout this last couple of months, when you've had all these worries, have you ever worried that your parents might in some way be involved in this conspiracy?
I thought about it. No.
Okay. Can I just check
Great, so we're going to stop the video here. And if you need a few moments to start scoring, I want you to focus on, have you pause the webinar now and focus on item 1, hallucination, item 2, delusions, item 3, disorganized speech, item 4, abnormal psychomotor behavior, and then item 5, negative symptoms. So go ahead and take a moment as I'm getting this off the screen to start scoring. And then once you're ready, just start the webinar back up and we'll review these together. All right, so let's start going through these. And the first thing I want to say is that oftentimes we'll have a client who will be on the fence, about whether they would score 1 point higher or lower. And so that oftentimes we can consult with a colleague, but I do want to just to normalize that experience that does happen, and that's why you'll also see some flexibility in that referral guide that we looked at it a few slides ago, where we're talking about mostly 0s and 1, mostly 2s and 3s, mostly 3s and 4s to accommodate some of that. So let's talk about hallucinations, and I think it would be interesting for you to have a discussion amongst yourselves if time permits, but in the event that it doesn't permit, let's capture what we've got here. During the interview, we saw that he was responding to internal stimuli, both just before she commented on that, and then a few times after she had commented on that, we see him also responding to presumably responding to internal stimuli. In terms of its effect on him, it seems to be quite distressing. So he attributes the voices to his roommates and reports that it's like they're coming from another room. It's not yet clear whether they're command type or derogatory or exactly what is the content of the voices, although we know sort of the general theme. And it's also not clear to the exact extent to which he might feel pressure to respond to the voices, but it does appear that he's quite bothered by the voices. And I think on that basis alone, we're in already the 3 to 4 range. Because we don't have a lot of information in terms of how much the voices in particular are affecting his behavior, and this is something where you as a clinician could certainly probe more around, it'd be difficult, I think, to know whether he would really meet criteria for a 4. We do know that he's engaging in some isolative behavior, but it's a little bit unclear. It seems to me that that pertains more to the beliefs that he's having, the paranoid and suspicious beliefs that he's having, and not just the hallucinations. So the rating that I provided on item 1 for hallucinations was a 3. The second is delusions. And here, just to review what we've got, we have paranoid delusions and thought insertion that have caused this client to be quite fearful and quite isolative. At this point, we don't see a lot of evidence. We see a systemized delusion with not a lot of evidence that it's generalized beyond his housemate. So he didn't talk about family or anybody else sort of outside his roommate or his housemates that this belief might extend to. Within the category of paranoid ideation, we have that his food was poisoned, that he's got a tracking device inserted into his head, and he has taken some measures to protect himself if needed, although he hasn't acted upon that yet. So he's armed himself with a knife and a baseball bat, which really speaks to the level of distress that he's feeling in response to these concerns. So I think here again, we're definitely in the 3 to 4 range. I think it's certainly a worthwhile debate about whether he would meet criteria for a 3 or a 4. I myself provided him with a 4 on this item. The third is disorganized speech. So what I observed during this interview was that his responses to the interviewer's questions were on topic. In other words, he was responding to the question that was asked of him. His speech appeared to be linear. He did indicate at some point that it's like he has too many thoughts in his head, but we don't see evidence of loose associations or flight of ideas. So I really didn't feel like there was enough to support a rating above a 0 on this item. For item 4, abnormal psychomotor behavior, I didn't see any awkward posturing. I didn't see any evidence of catatonia. We didn't observe him walking, but he was gesticulating a few times while he was speaking, and I really didn't feel like we had enough to provide a rating above a 0 for this item either. And then item 5, which is negative symptoms. So again, we're looking here at restriction in their emotional expressiveness and any evidence of avolition, any evidence that they're not able to start or complete tasks. We're looking at their body language and we're looking at poverty of speech or as well. And I really did not see any evidence in his intonation, his facial expression, or his ability to self-initiate behavior. There didn't seem to be a lot of evidence. In fact, if you look at his face while he's speaking, you'll see his eyebrows furrow and lift. He does use his hands. So it's questionable to me whether you even have enough for an equivocal rating. So I think certainly here we're a 0 or 1. And I, definitely spoken with some clinicians who viewed this video and rated him a 1. I myself tend to be a little bit more conservative on this item and rated him a 0. The other thing that you want to be aware of is that folks who are already on an antipsychotic medication, or certainly if they're on more than one antipsychotic medication for some reason, that you may see some of these things that look very similar to negative symptoms that might be attributable to their medication. And if you have a question about that, you can always talk to their prescriber. All right, so that was our practice activity, and I hope you have an opportunity to discuss this amongst yourselves. Please, I'll provide my email and phone number at the end. Follow up with me with any questions that you have. So in summary, CBTP stepped care is a way of changing the standard of care for clients with psychotic disorders. And we're doing this agency by agency by agency, and really provider by provider. So again, I really want to thank you for dedicating time in your schedule to maybe change up the way that you've been interviewing folks with psychotic disorders to help assist with the CBTP stepped care referral process. CBTP should be considered for all new and existing clients with a psychotic disorder. So initially, we know that the rollout might be a little bit slow as you identify existing clients on your caseloads that meet criteria for a psychotic disorder and start engaging them in the conversation around this program and the referral process. But eventually, I do hope that it's something that is offered to everyone. So at we'll talk about point people now. So I'm the developer of CBTP stepped care model. I work with my team at the University of Washington, which consists of Jeff Ross Kelly, who is a staff trainer and consultant and a licensed clinical social worker, Eric Strachan, who, like myself, is a clinical psychologist and is the group CBTP consultant and also acts as a consultant on our individual CBTP consultations, and Mackenzie Hughes, who is our program coordinator. That is our implementation team. And then please connect with the CBTP champions who've been identified at your agency or your managers. So thank you again for helping to make this work possible. I'm very excited to roll out CBTP stepped care at your agency. If you have any questions whatsoever, please feel free to address them to me by email or by phone. I am open and available to help. Thank you.